I don't think that there's any question that we're seeing a real tension in our ability to go ahead and recruit new urologists to clinical practices. Right now, those of us, for example, integrated medical professionals, my practice is in the New York metropolitan area. It's a reasonably high demand area for people to live, so we're not experiencing quite the same recruitment problems as clinicians in other areas of the country, particularly those that are in more rural areas. One of the things that we have to grapple with is that urology is one of the oldest surgical disciplines, with estimates of the average age of the urologist ranging from 55 to 57. So when we're dealing with the fact that that many clinicians are toward the latter end of the career, and also given the tremendous administrative changes in the Affordable Care Act, physicians that may have been in practice for a longer period of time may well look to retire earlier, I think we have the potential of having a very serious problem. We're dealing with limited resources from a federal standpoint, so the amount of support that is being provided for graduate medical education is being severely curtailed. So as challenging as it is right now for practices to recruit physicians, it may continue to be more challenging if the influx of physicians is not equal to the attrition rate that we're presently seeing. So, yeah, I would have to concur absolutely that we are starting to see a serious issue in recruitment, and that issue is going to get more. Adding to that tension is the changing dynamic of clinical practice. We're now seeing that, and it's certainly not true across the board, but the perspectives of the present generation of people coming out of training are somewhat different than the perspectives of people that came out 20, 30 years ago. At this point in time, physicians are much more likely to consider hospital employment as a viable alternative to being in private practice, which is not a phenomenon that we observed in the past. As there's continued reimbursement pressure on practices, that is a trend that may also increase as the community practices, again, particularly those that that are smaller and may not have a lot of resources at their disposal, may simply not be able to compete from a financial standpoint and be able to offer compensation packages that are attractive to urologists coming out of training. So this has to be balanced against a very significant other tension that exists. And that is that we're seeing a tremendous aging of the population. You know, the reality is, even though urologists treat both sexes cradle to grave, a very significant percentage of most urology practices is an older population. Depending on what you do in a general urology practice, the estimates run from anywhere from 40 to 55% of your population is going to be in the Medicare population. As the baby boomers age and we see an influx of people into that age range, we are going to have some real challenges in terms of providing care. When you add that to the influx of people that are going to be provided with insurance under the Affordable Care Act, we may very well find that a manpower shortage becomes rapidly exacerbated. And data presented here at the AUA indicates that the relative undersupply of urologists may very well be tremendously more accelerated than we previously thought. I think the most important thing that urology can do is really gather accurate data. You know, the decisions as to how to allocate these resources, quite frankly, are beyond the scope of the urological community. We can advocate for our specialty and we can advocate for the resources, but we can't advocate with policymakers unless we have very strong and very accurate data. So I think it behooves all of us in the urological community to support the efforts of the American Urological Association and other entities when we're striving to understand how work is measured. And so you need to measure how productive are clinicians, how long are they going to be in practice, what are the factors that are going to keep them in practice versus having them retire, what are the motivations of residents that come out of training. These are very hard questions that need answered, and until we have accurate answers to those questions, we actually can't formulate a proper legislative strategy to go ahead and address them. I can tell you from the perspective of the large Urology Group Practice Association, we're committed to working with other organized the rest of organized urology, including the AUA, the AACU, the Society of University Urology we've had interface with, to go ahead and discuss these issues of graduate medical education and how we can both gather the data and then present that to federal policymakers to make sure that our specialty gets the resources that it deserves.